Good morning, everybody, and thanks, Dr. Hari, for the opportunity to present about optimal mobilization strategies for autologous transplantation. I'm Luciano Costa. I'm an associate professor of medicine at the University of Alabama at Birmingham, a bone marrow transplant and a myeloma physician. So I'd like to start by reviewing with the audience the mechanisms of mobilization. We know the hematopoietic progenitor cells of interest. They are home in the bone marrow, where they're anchored by several biochemical binds between the stroma and the endothelium and the hematopoietic stem cells. We know for a long time that those hematopoietic progenitor cells do circulate at a very low number through the peripheral blood and are constantly changing territory. But we know that process can be expedited by breaking some of those anchors, which is exactly the mechanism of action of growth factor. Of course, this was pioneered in an empirical way, but we now know that how G-CSF promotes mobilization is essentially by expanding the myeloid component of the bone marrow, releasing in the environment several elastases and metalloproteases that are responsible for breaking some of those links, while also downregulates the expression of some of those anchors that keep the stem cells attached to the bone marrow. More recently, we have had the advent of CXCR4 inhibitors that essentially occupy that binding site in the CXCR4 and the hematopoietic progenitor cells, essentially preventing the cells from rehoming into the bone marrow. We mobilize those cells into the peripheral blood. They are collected by apheresis for transplant. And a very early question in the field is, how many cells are needed for transplant? And this graph is, even though it's 20 years old, gives us a good idea of the relationship between a number of cells transplanted and speed of engraftment. And the bottom line is, up to a certain limit, the more cells you transplant, the faster engraftment you're going to have. That is not so clear for neutrophils, but it's certainly very evident for platelets. So Dr. Steve, who happens to be here with us this morning, published this study about 7 years ago, looking at the long-term, 12-month graft function here in terms of a proportion of patients with greater than 150,000 platelets. And we can see very well that a more robust graft leads not only to faster early engraftment, but also to a more enduring graft that will sustain adequate blood counts in the long run. This becomes even more important in this day and age as we incorporate other therapies into consolidation and maintenance. Many of the therapies will have some myelotoxicity, making it just more important to have a robust graft that can endure the toxicity of those agents. So it's more better, and there are certainly several aspects supporting transplanting more cells. For once you get fast engraftment, it's not clear if you get better survival or if it's just an epiphenomenon, but you might get shorter hospital stay, although it hasn't been definitively proved, less resource utilization, less transfusions, lower period of neutropenia causing less infection, less use of antimicrobials. But there certainly are some cons of pursuing a higher dose of cells, one being the need for more apheresis sessions to procure the cells, more use of mobilizing agents with a higher cost, and the hypothetical concern about potential tumor contamination if you try too hard. Back in 2012, in an effort that got published in 2014, Dr. Girault led some of us in the field on producing a consensus paper trying to come up with some recommendations of how many cells to pursue and how to pursue the cells. And it was agreed that the minimum recommended stem cell dose would be 2 times 10 to the 6 CD34 cells, but acknowledging that the ideal target would really be between 3 and 5 million cells for transplant. So how do we get there? What are the options that we have in 2018 to procure the cells? The easiest, the most practical one is certainly cytokine mobilizing agents, most commonly used being G-CSF, but also with some data on G-CSF. I'm going to share with you today some data on pegylated filgrastim and as well as some other newer formulations of G-CSF. A not so new approach is chemotherapeutic agents in combination with cytokines, either a disease-specific chemotherapy regimen often used in lymphoma, RIs, RD-HAP, and others, or chemotherapy given for the sole purpose of mobilizing cells, most commonly used being cyclophosphamide and etoposide. And more recently, we have the combination of cytokine and the CXCR4 antagonist, Plerixafor, and even some early and small series use of chemotherapy plus cytokine plus CXCR4 antagonist. So, but what is the problem we're trying to face here? So, I think if it just G-CSF was being practical and safe, was efficacious, then we wouldn't have to discuss much past that. But this is a paper from Dr. Gertz at the Mayo Clinic almost a decade ago, reporting their experience with growth factor mobilization only. And that gives you a very good idea of what that strategy does produce. While some patients get optimal mobilization, and many more get some okay mobilization that can still proceed with transplant, the rates of failure are pretty high. About 30% of the patients with lymphoma who undergo G-CSF only mobilization do not have enough cells, do not have the minimal number of cells to proceed with transplant. In myeloma, used to be lower, here 14%, but that really makes you wonder how the performance of that regimen would be in this day and age where essentially everybody gets lenalidomide up front, which is a drug that is known to impair mobilization. So what strategy to choose? Of course, growth factor is simple, less toxic and less expensive, but as I show you, has a high risk of failures and leads to low yields of collection. Chemotherapy plus growth factor has the hypothetical benefit of having an anti-tumor effect. And Dr. Howard is going to show you data later today that seriously question that assumption. There's no doubt it leads to higher yields, but has some toxicity, high cost, and the risk of failure is not much reduced from the risk of failure that you have with G-CSF alone. Growth factor plus Plerixafor has a lower toxicity, is a strategy with the lowest risk of failure, but of course, the greatest concern is always cost, and there's some Plerixafor-associated toxicity that tends to be minimal and limited to the GI tract. So the one question is, can we predict failure? It would be very nice if we could take a patient who is being proposed for autologous transplant, look at a series of clinical features on that patient and say, this is a patient who's going to do just fine with G-CSF. Let's take the cheapest, quickest, easiest approach. That patient is a patient who is going to fail, therefore let's use chemotherapy mobilization or let's use Plerixafor plus G-CSF. And those are factors who have been in several series in the literature identified as risk factors for poor mobilization. And age, lymphoma versus heavy myeloma, platelet count prior to collection, prior use of lenalidomide, several drugs such as bendamustine, fludarabine, extensive radiation, and some things interesting such as smoking history and even diabetes. So we tried to answer this question in a very practical way. A few years ago, we combined data set from then my institution, MUSC, with the Mayo, and we got near 500 patients undergoing G-CSF-based mobilization with multiple myeloma, and trying to build the most robust possible model to use clinical features to predict mobilization failure. And the bottom line is no matter how we define poor mobilization, either less than 20 cells to the peripheral blood or less than 10 cells to the peripheral blood. Clinical characteristics by themselves are not sufficient. You're going to either err in one side or the other, either undertreat somebody who is that you think is going to be a good mobilizer but is not, or overtreated somebody who you think is going to be a poor mobilizer but mobilizes very well. So let's look at chemotherapy plus growth factor. The most commonly used regimen is cyclophosphamide, has about 30% risk of infection and 5 to 20% risk of failure in several series in the literature. A couple other agents that we don't get to talk a whole lot, but there's some interesting literature, one being vinorelbine, and 35 milligrams seems to be perhaps the ideal dose where you get great rate of success and a very low rate of infections and very infrequent need for transfusions. I'm not an adopter of chemotherapy mobilization, but if I were to do, this would probably be my agent of choice. Quite a bit of data also about etoposide, highly successful, particularly in myeloma, however, frequent need for blood products due to hematologic toxicity, and still about 10% risk of infections due to fever, admissions due to fever neutropenia. Many years ago, we and others evolved with the concept of preemptive Plerixafor. The strategy of G-CSF plus Plerixafor gives the opportunity to observe real-time actual mobilization capacity for that individual patient, and then adjust your strategy based on the patient's ability to mobilize cells. So we use a strategy where patients mobilize with growth factor for 4 days, then you read out the peripheral blood CD34, and depending on that number, you either proceed to collection or you add Plerixafor to collect the next day. And this is possible based on the knowledge that the CD34 in the peripheral blood very narrowly predicts the apheresis yield, and the knowledge from randomized phase 3 trial that the use of Plerixafor leads to about a 3-fold increment on the yield of collection. So if you know how much your patient is likely to collect on that ongoing mobilization, you know how much more the patient would collect if you add Plerixafor. You can do some minimal modeling to come up with a decision-making algorithm that looks like this, where for each target that you desire for collection, you have a break-even number above which it's most cost-effective to just proceed with G-CSF, and below which is more cost-effective to add Plerixafor. When we did that, we found out that about 68% of the patients did indeed require Plerixafor. The system, this regimen was highly predictable and led to very low risk of mobilization failure. Others have compared chemotherapy mobilization with growth factor plus Plerixafor. This is an analysis of 33 patients in each group. This is not a randomized study, but a retrospective study. And the bottom line is almost everybody collects. Essentially, there are some patients who miss the target on the chemotherapy plus growth factor, but there's more weekend apheresis due to the lower predictability of the chemotherapy-based regimen and a much higher rate of infection. And the interesting thing is the cost seems very similar between the two strategies. At my private institution, we also did a retrospective comparison between chemotherapy mobilization and an approach with just-in-time Plerixafor. And we found that first, our mobilization algorithm was much more predictable, and only 2% of the patients did not even proceed with collection due to the low CD34 count. Everybody else collected within 3 days, the vast majority in the first 2 days, while 22% of the patients with chemotherapy mobilization never went to the machine due to insufficient mobilization. So the success rate was 98 versus 78%, but 30% of the patients with chemo mobilization did require hospitalization due to infections versus only 2% with G plus P. And interesting enough, the cost was somewhat even less with growth factor plus Plerixafor than was with chemotherapy if you include the costs associated with those admissions for fever and neutropenia. And this is not even counting what's probably the highest cost burden, which is the cost of remobilization that is very expensive and often unsuccessful. More recently has been some data on TBO-Filgrastim, which is not technically a biosimilar, but is another flavor of filgrastim. So this is a comparison, and you can see the performance of those agents on a just-in-time approach for Plerixafor is nearly identical, with a very similar utilization of Plerixafor and very similar collection yield. So for all practical purpose, I consider those two drugs to be equivalent. We had several years ago the opportunity to test the use of Pegfilgrastim. As many of you know, Pegfilgrastim is a pegylated version of filgrastim that is used as a flat dose, not a weight-based dose, and is a single injection as opposed to multiple and daily injections as you do with filgrastim. And we compare our performance of our filgrastim with just-in-time Plerixafor versus Pegfilgrastim with just-in-time Plerixafor. And essentially we found that the Pegfilgrastim was a better mobilizing agent, and that results in lesser use of Plerixafor and very similar or nearly identical mobilization outcomes. And keep in mind that this was 12 milligrams, which is double the standard dose used for prevention of fever and neutropenia, although we have some later data showing that 6 milligrams, which is a single vial, have very similar performance. More recently, at my current institution, with the interest of optimizing resource utilization, particularly apheresis time, and essentially accommodate the growth of our program, we have moved to a regimen for Pegfilgrastim plus Plerixafor upfront, and this is being we presented this at ASH last year, and my type 1 pharmacist Nicole, sitting back there, has a paper ready to be submitted. But the approach here is Pegfilgrastim 6 milligrams. 2 days later, Plerixafor in the evening, followed by collection. We don't bother, we check CD34 for data gathering, but we don't make any adaptation, don't wait for the result for reasons that I'm going to show you in the next slide. And after that, if the target is met, the mobilization stops. If not, you go for a second and even a third day. We don't go past 3 days. And this is our performance in 235 patients. Some of the patients have a target of 3 million, the mostly lymphoma patients. Most of the myeloma patients, we have a target of 6 million cells. And bottom line is the vast majority of patients do meet the target, 87% and 82%. 95% of the patients reach at least 2 million cells, which are sufficient to pursue one transplant. Very high baseline CD34 count in the peripheral blood. Of course, Pegfilgrastim has a reputation for being costly, so we seek to compare the cost of Pegfilgrastim to what would have been the cost had we used filgrastim, assuming those drugs have the same mobilization potential, which might not be the case. Pegfilgrastim may be a better mobilizer, but we didn't want to depend on that. So this analysis projects the estimated cost of pharmaceuticals, that is the growth factor plus Plerixafor, for patients who had a target of 3 million and patients who had a target of 6 million in total. And in all those comparisons, they favor Pegfilgrastim. Of course, since filgrastim dose is weight-based, that comparison becomes more favorable to Pegfilgrastim as patients get heavier. We are in Alabama, which is probably the second heaviest state in the nation. So we don't get a lot of patients waiting less than 60. So the vast majority of patients, the cost comes in favor of pegfilgrastim. So we went that way, considering that is cost beneficial, at least cost neutral, and is more convenient for patient and staff. So just to finalize, I want to share go back to some of the consensus recommendations in terms of goals on mobilization. When we met in 2012, we recommended that the goals include reduction of overall failure rates to less than 5%, which is achievable with the drugs we have today. Minimize mobilization-related complications, optimize the use of resources. Pre-apheresis CD34 should be used to identify poor mobilizers and gives the opportunity to intervene before we have a flat-out failure. And preemptive Plerixafor is a good strategy in that regard. Consider upfront steady-state mobilization with Plerixafor plus growth factor. That strategy will offset the need for remobilization, which on itself is very costly and tiring to the patients. And some early interest in the use of chemo mobilization plus Plerixafor plus G-CSF. I didn't show a lot of data on that, but that anecdotally can be used as a remobilization strategy. Just one slide about remobilization. Cytokine alone should never be used. It's the least efficient of all the methods. We recommend that any patient who did not receive, for whatever reason, Plerixafor as the initial strategy should receive Plerixafor in the setting of remobilization strategy. Chemomobilization might be used, particularly in patients who have failed cytokine-only mobilization, with some interest of adding Plerixafor to that combination. And last resort is bone marrow harvest, which I think many of us have done anecdotally, but there's really not a lot of data to indicate that approach is necessarily the best versus deferring transplant altogether or even going for an allogeneic donor in the case of lymphoma.